Good afternoon, everybody. Thanks for coming to our symposium. And I think everybody knows that we're here today to celebrate the accomplishments of our alumni and friends of the school. And people, often ask me. We have several deans here today, so can't make too many dean jokes. But David Vlahov, who is dean of the UCSF School of Nursing, and Donna Peterson, who's dean of the University of South Florida School of Public Health. But people ask me, why do we have such a great school? And it's easy. We recruit great students who become great alumni, and the alumni go out and they change the world and they make us look good. So today's a day to bask in that reflected glory of our alums. And I want to thank everybody who made such effort to get here today, who wedged us in between the earthquake and the coming hurricane. And thanks to Philippa Moore for her prescient scheduling of this. A day on either side would have been not good. So at the end of today's session, we're going to have the award ceremony. But we thought that given that we have our illustrious alumni here, we'd start with a panel discussion. And so we're going to ask three of our recipients to come and up to the stage, and I'll ask them in a few minutes. But I do want to say that we have 14 of our alumni won awards this year. And this is the most that our school, and I think any school in the university, has received. And it's 40% of all the awards given out by the university. So just as in so many things, we swing above our weight here. And it's a real, it's an affirmation of what we all know about our students and our alums. So there are three panelists. I'm going to ask them to come up as I call them. And the first is the Honorable Nils Dallaire. Nils, many of you know, is the Director of Office of Global Health Affairs at the U.S. Department of Health and Human Services. Next, I'd like to ask Diane Rowland. Diane is the Senior Executive Vice President at the Kaiser Family Foundation. I think many of you know the work of the foundation. And when we were dealing with healthcare reform, I have to say that the best resource, other than our faculty, but the best resource is the Kaiser Family Foundation website. It's just an incredible treasure trove of information and putting things in perspective. Is that it? Thanks. And last but not least, Joanne Katz. And Joanne is professor in the Department of International Health, and she's associate chair there. And she directs the Global Disease Epidemiology and Control Division here at the school. So please have a seat and join me in welcoming. So there's going to be time. We're going to go for maybe a half an hour or longer. But I wanted to just kick it off by asking some questions. And I think from your little book that the topic we're going to talk about is navigating politics to achieve public health goals. And I think the three alums who are up here have had different experiences and maybe different perspectives. And I'm going to start with Joanne. And much of Joanne's work, if not all, has been outside the U.S. And I know you work in Nepal and other places. And so you've had to deal with a lot of issues related to politics, and governmental change and ministries of health. I would ask you, as you think back on that, what's been the biggest challenge you've had to face in terms of politics impacting on public health and perhaps public health practice?
Yeah, so thanks for this question. And I was giving some thought to this. And I would say that when I first came to Hopkins, this was in 1982, and Al Sommer gave me my first job here. And he set me to work on analyzing data from his vitamin A studies. And I've always been intrigued by the fact that there have been now probably, I can't even count how many randomized trials, and Nils was one of the people who did one of those trials in Nepal.
A random.
And there was so much good evidence about the impact of vitamin A supplementation on child survival. And yet, even today, there are many people, and India is a good example of this, where people still are, have their concerns about whether vitamin A actually has an impact on child survival. And on the other hand, you take an example of the original AZT trial that was done to prevent HIV transmission from mother to child. And there was one study done in the United States, about 300 women, and it became instant policy and program. And you couldn't do another randomized trial. You couldn't use placebos, anywhere else in the world. And so, I think one of the big challenges is how to assess evidence and how to use that evidence to produce policy and programs. And I don't think we really know the answer to exactly how to do that well. So that's sort of a challenge, I feel.
So do you think that the fact that HIV was a relatively new field, there wasn't a lot of literature, there was an intervention that was so visible, or a disease that was so visible and so deadly, that
Sure, I think that played a role. On the other hand, you could say with vitamin A, it was a non-invasive intervention, inexpensive, easy to implement, cheap, so sort of what was it about that interaction with public health people that made it so critical to get a really strong evidence base before people could make changes?
We could spend the whole day talking about that one. Because I was an observer, I was in the School of Medicine and, but teaching in the school, and I think but let's not do that. Maybe we can say that I have some thoughts. So when you talk about Al, he hired you to do data analysis. I didn't realize that. So Al is not able to be here today. He sends his regrets. But keeping on the theme of deans, Al's missing, but DA is here, I believe. DA Henderson, who's Dean number 8 of the school. So Al always tells a story about, he was looking over the output and he saw this, this effect on mortality of vitamin A. But I didn't realize you had done the analysis. You had circled it in red and said mortality decreased.
He always talks about the holy cow moment.
Yeah, right. Yeah. So, okay. So thank you. So we'll come back to you. So Diane, we all know you live in California, which is...
No, I actually live in Washington.
Oh, you live in D.C. Okay, so Kaiser Foundation's in California, right? And which has had from the outset, from the outside, looks like some aspects of dysfunctional government, and now it looks like we have that here, and in the Congress, and we live in this time of intense politics. I guess partisan politics. It reflects how people are in this country. Given the Kaiser Family Foundation's role as an advocate for health and for healthcare reform, how do you see politics affecting the work of the foundation?
Well, I think it's really been a different road since we began with the enterprise that started here, actually, at Hopkins in 1991. We set up a commission on the future of Medicaid, and the foundation funded it, and it had a national advisory committee. And then in '93, thinking that President Clinton was about to get health care reform, we moved the commission to Washington, D.C. to try and look at how to make the low-income components of any health reform work, which was the purpose of the commission to begin with. And then suddenly learned that facts don't always matter, and a lot of what matters is people's myths and not their realities. So I think one of the challenges in my whole career has been to try and use research and data and information to try and bust some of the myths about the fact that uninsured get all the care they need. They can go to ER anytime they want and get better care than anyone with insurance. So it's really been a political environment in which there are people who just don't want to believe, and there are people who you need to just keep repeating over and over and over what the numbers and the data are. And I think that's been what I was trained so well to do at Hopkins, and what has made the Kaiser role so important in a political sense is that it's hard to argue with data. It's easy to argue with rhetoric, and I think that's been really one of the most important contributions that we've made in health services research, to really begin to quantify some of the ways in which lack of care influences people's health, that if you're uninsured, you don't have the health care you need. We've not always been able to make the arguments as strong about what might be a better system for health care coverage than patching the holes in our existing system, and I think that remains a challenge. When I first started working on these issues in the 70s and then worked for Congress in the 90s, it was not the same bitter political partisanship that we have today. So we often worked with Republican and Democrat staff together to try and figure out how to implement a policy. Today, you can't even brief them in the same room. If you're doing a briefing, you have to do one for the Republican staff and one for the Democratic staff. And so I think there's just...
And do you say the same things?
You say the same things, but you get very different questions. So I think that's been the real challenge, is just how do you cut through the rhetoric to have people care about people, and how do you keep the focus on people, not on the budget?
Thanks. So some of the same themes, though, about the power of data and lack of acceptance sometimes of evidence. So Nils, you work for the government now. I mean, obviously everybody...
I do, and I'm here to help.
Yeah, you're here. I trust you. But you have worked for NGOs, and you know, and you've been in academics, and you've been at this interface of those kinds of organizations, and having seen both sides of that coin, you know, from being in the field, implementing, being an advocate, and in government. Obviously, you're in the executive branch, which is different than some of the other branches of government in terms of how they see things. But what insights do you have about how politics affects achieving public health goals?
Well, the reason I went into government service in the Clinton administration was because I had seen in Nepal, as Joanne was saying, when I was out there in the 1980s, the impact of U.S. government policies on the ground, particularly in terms of women's health. The Mexico City policy and its effect on turning away women from clinics who had back alley abortions, where people were afraid to treat them because they thought they'd lose their U.S. government funding, with the U.S. as the largest funder of health programs in many countries around the world. It was very clear to me that having a thoughtful voice in terms of policy making made a real difference in terms of the lives of people. I think Diana is absolutely right that facts don't always matter, but I think those of us who come from a fact-based set of disciplines in public health do have an obligation to try to make facts resonate, to try to make them make sense, to get some messages that are based on the facts that somehow fit into the prevailing sociology and mythologies, and then to build on that and to resonate. And I think the interplay between the knowledge generators in the academic world, the implementers in the NGO world, and the policymakers in the government world is a very important triad, which can work extremely productively on the best of circumstances. And we've seen sort of the counterpoint there, and some of there seems to be a strong trend in some of the circles, both political and quasi-academic and civil society, to do away with the concept of probability distribution, that everything is bimodal, either yes or no, and usually faith-based if it's on that basis. So I think we are facing at this point a very real difference in worldview in our body politic, and it's important to maintain a thoughtful but meaningful dialogue there.
Yeah. It seems to me, you know, I chair the Association of Schools of Public Health, so I go down to D.C. a fair amount, and it's been amazing to me how there's been a sea change in the view of research, data generation, that where, you know, it was considered by almost everybody to be a good thing in the past, and we've lost that, I think, and it's scary for the future. So lots of good thoughts. I'm going to open it up to the audience to see if there are additional comments or questions. If not, I have some things I want to talk about. So, okay. So let me ask. follow up on your point, Joanne, about vitamin A and why it's been tough. And it's a good thing it's been tough, because Al loves, Al's a
good
great
story
advocate.
on it, yeah.
But it seemed to me that, those studies came out not long after I finished my MPH, right? And obviously we knew that there was a big child survival push, and we knew that things like educating everybody and educating women and providing better nutrition and education was just good for children, good for the families. I think there was a visceral pushback by people, and we all would think that's true, right? That's true. But the fact that such a simple intervention, kind of a silver bullet, that you could go in and not deal with these other issues, I think some people had a visceral reaction to that. It was just too easy, and it might take away the lever that you have to do these other things. Do you think that? That's what I think. I wonder if you...
Yeah, I mean, I think that there was certainly, and particularly if you look at what came out of India and the dialogue from India, there was certainly certain well-placed researchers within India who felt that this was a silver bullet, and that really you should be doing development work, and you should sort of look at the picture as a whole, and nutrition, and not be trying to give sort of individual supplements to people. But I'm not unsympathetic to that point of view, because I think that obviously that's what we would like for everybody in the long run. But if there are simple things that you can do for people in the interim, I think you should do them. And if you can save lives now, I think you should do those. And you can, and I think it's a balancing act to try to take your resources and say, how many things do we put towards sort of more longer term goals, and then what do we put towards things that we can have an impact on right here and now. And so I feel you should do a bit of both, and I don't think one or the other is.
Right. But it's sort of the same point Diane made about preconception affecting how people see reality, right? That especially people who aren't used to looking at data, right?
I also think one of the challenges today is that we've lost a sense of community. Public health is all about taking care of populations and communities. And if you look at how the debates go on, it's all about individuals and who should pay for what, and why should I pay for some poor person to have more coverage. And so the real challenge is population health really needs to be reestablished. And it's a concept that really has kind of been lost in at least the policy world.
Yep. Yeah, Scott.
I wonder if any of the panelists have stories they could briefly share about how your own work was imperiled by local politics. Not so much whether your work was accepted because of the politics, but whether your doing of your work was imperiled because of the political situation in which you were working.
I can comment about that going back quite a number of years to my work in Nepal. In that context, I was working on a field program to get childhood pneumonia treatment out into a poor area. And both the medical establishment in Nepal and some of the local leaders were fiercely resistant to the idea of the medical leaders, because clearly only doctors are qualified to dispense antibiotics wrong. And the local communities, because there was the risk of interfering with power structures, with control over resources, control over services. We were able to work that through, largely by maintaining a very light touch and a very strong Nepali face on the process. But it required an awful lot of patience to do that.
Diane?
I guess I'd say that one of the real advantages that I've had working for the Kaiser Family Foundation is that we don't apply for grants, and therefore we're not a grantee of some of the political powers. And often in our work with other researchers, we've been able, through giving them support, to get reports out that would have otherwise been squashed. But it's always very difficult when put out the numbers and you put out the analysis, and sometimes even your friends say, well, that's not helping our case. But I think it's very critical to always just tell it like it is, but that can really jeopardize some people who don't have the independence we've had as a sole funder.
Joanne?
I had two interesting experiences, and I see Keith West in the audience, and he'll remember this well, from 1986, which was when the Ferdinand Marcos government fell, and we had a project that we were trying to do in the Philippines, and you know, through all the political turmoil that went on there, we were unable to actually implement that project. And you know, and I've thought about it a lot over the years as to what went wrong there and what we might have done differently. And I still, again, don't know to this day. I think we were just in the wrong place at the wrong time. And
It's
yet
hard to
we
blame
were
that
able
on Keith, the downfall of Ferdinand Marcos.
He was the CIA agent all along, right? But then we were able to move that project to Nepal, and in spite of a civil war and many other things that were going on there, we were able to implement that same project there successfully. And I think what Neil said is correct, that having really good local collaborators, having, as Americans, sort of stepping away from sort of the limelight and allowing our local colleagues to help us take the lead and be responsible and be the face. Having a light touch, I think all of those were very helpful in being successful there.
Okay. So I saw in the back there, and just wait till the microphone comes, okay, because we're taping, and then Len, and then here, okay, and then there.
So I guess this is a comment that I would be curious to get your opinion on. Recently, I've been thinking a lot about, like I forget the woman's name in the middle, but I apologize for that. Diane Rowland. You know, the individual framework and the population framework with regard to like interpreting policy and law. And it seems like politics would be benefited by the population perspective that public health has to offer. You know, insofar as two populations, you know, experience different outcomes because of their social environments, it would suggest that there ought to be different interventions for those populations. But then what do you do when the population to which a law is being implemented, you know, which is in today's politics, we're often deciding between, you know, states' rights and the implementation of a law on a state level versus the federal level, but neither of those distinctions of a population often coincide with the relevant distinctions of a population in terms of, you know, in public health, you know, more relevant distinctions would be based upon perhaps socioeconomic status or other distinctions. So what do you do? Like, how do you implement the best intervention for a population when those two things don't coincide, the relevant population and the population for which the law is actually being implemented, if that makes sense?
I think you pose the great challenge, and I think in trying to do anything in domestic policy, we always struggle with what should be the national standard versus what should be the difference by state, and many times that leaves some of the populations that would be perhaps better tended by federal standards to be less well cared for at the state level. Clearly, one of the histories we've had is looking at disparities and trying to figure out how to improve access to care for some of the lower income and more vulnerable populations, some of the people of color who really stand to lose from many of the state implemented policies. And that has played out fully in the implementation of the health reform legislation, where there were so many areas that were left to state discretion. So even though we think we have what is being called a national health law, it's actually going to be very differently implemented depending on which state's there. And none of that is usually based on public health, looking at population criteria. Most of it is based on kind of the politics of where the money goes at the state level or where there are stronger holds. So I think we really have a challenge as public health practitioners to say, but this is how, if you want to achieve this improved health status, you should go about designing the policy. But that's really rarely been a criteria in the way Congress enacts healthcare legislation.
So Len, Mike, please.
You've all talked about data versus myth or data versus faith, and this has been a persistent challenge for the public health field to have policy based on evidence. But it seems that we're in a whole new day now, that is not the fight. The fight is not about data versus non-data, but whether even accepting the data, government has any responsibility at all to meet needs, whether anybody has any human rights to health, and we're like in a totally different conversation, both globally and domestically. And I'm interested in your perspective on how we address that challenge, where public health is caught up in anti-government thinking and rhetoric, where no data makes any difference.
Mm-hmm.
Well, I think, Lynn, that actually is an appropriate topic for political discourse. I mean, I think people are not entitled to their own facts, but they are entitled to their own opinions. And the issue of the role of government is, I think, an important social debate that needs to take place. I'm less troubled by that debate than by the wholesale elimination of consideration of facts and data. I think that's it can be a healthy dynamic as long as it maintains an actual debate quality rather than a religious war fervor.
Diane or Joanne, did you want to say anything?
I just really think, though, that it isn't a debate right now. It's just a set of talking points on two sides, and that there is a lot of misconception about what government does and doesn't do. I mean, one of the jokes we always have is the people who stand up and say, keep the government away from my Medicare program, as if Medicare had nothing to do with the government.
Barbara Starfield loved that line. Yes, yeah.
And I do think that it's, right now it's hard to see how you could come up with a sense of community for this country, because it is so divided along the lines of what is the right role of government. We used to debate whether the federal government should do it or the state. Now we're debating whether any government should do it. Mm-hmm. And I think that is a whole different level of debate than I've ever seen in my career.
I think, Patty, were you next? Yes. Microphone here, please, up front.
Sure. Just a quick question about the sort of proliferation of social media and how that is having an impact on some of the work that you're doing, both in the international space, so things like Facebook, Twitter, how those are being leveraged to mobilize from a political perspective around public health issues and public health research.
Well, I'd certainly say that in my area, it's making life harder rather than easier. We used to really count on, as one of the ways of reaching the public about problems and challenges and solutions, the media. And with the downsizing of most of the major news outlets, and with the lack of reporters who have spent a career covering health, so that I talk to a reporter probably every 3 months who's, I'm new on the health beat, and then they're gone in 2 months and they really have very little background. So that what happens is that whatever the blogosphere puts out becomes fact. And when I talked about fact versus reality, I do think it's that availability of, well, I found it on the web. It was on the web, so therefore it's true. And it makes our old standards of peer review and scientifically sound information challenged against just whatever anyone wants to kind of post on the web and cite.
So Patty, let me ask you, you're probably the expert in the room, right, on social media and mHealth, and how would you answer the question you posed? You got to get the mic in.
I mostly work on the international health side, so which is very different, and so the use of mobile technologies and social media has been high profile around some of the major revolutions that have happened, but not so much around mobilization around healthcare or public health issue, which is why I was really curious about, what role it's having here in the United States, where it seems that particularly among the youth, that if you sort of separated who was either posting and or reading some of the information that's coming out, and then also strategically how your organizations have started to much more proactively engage the public through various technology outlets. And I think public health in developing countries has been quite slow to start looking at technology and is now really ramping up. Here, I think it's been even slower. And so I'm curious to see how.
Well, one comment I would make on that is, I think there's, as you said, I get a sense that there's a lot of hype about, mHealth and mobile technology, in the overseas context. But the one concern I have is there's not very good data, again, about is this useful, how does it work, and so there's a lot of discussion about using cell phones to provide medical advice to rural areas, things like that. And I think there's a lot of promise for these technologies, but I also think we should go about this in a systematic way, and we should test these interventions, and we should see if they work effectively and use the same sort of rigor as we have with other kinds of interventions to see if this works well. In terms of sort of locally here, we've had, Bob Black knows, we've had some interesting discussions about the use of Twitter and, in trying to sort of get out our messages about what we do and trying to sort of tap a very different audience than, say, the regular media. But I also have the same sort of unease about, again, information out there, but what is the quality of that information and how is it going to be used and perceived? And I think there are some websites that are better known for their quality, but still, it's just sort of a free-for-all. And I think harnessing what's a very wonderful technology, which is the web, to do something useful is going to be our big challenge.
Let me just add very briefly. I think there are two risks in this whole arena. One is magical thinking, and I would totally agree with Joanne that some of the ideas for how mHealth can save the world are really based on magical thinking and not on facts or experience. But the other one on the opposite side is sort of the denialism, saying, well, this is the social media create more problems than they solve. The fact is we have them, they're growing. We have to find, as responsible public health leaders, we have to find ways of harnessing them, of getting direction signals, of making sure that they serve a better purpose than they might otherwise. And I think that's our challenge.
Okay. So I see you shaking your head. You're agreeing?
Yes, no, I totally agree with that. The evidence around mHealth is still quite weak, but it's growing. I mean, there are a number of randomized controlled trials that are underway that are now starting to show what the effects of mobile technologies are.
Okay. Thank you, Penny. Okay. Yes, please. Next to Steve. Yeah, right there. Oh, you're pointing over that way. So who's got their hand up? Somebody has their hand up. No? Okay. Oh, you're waiting for the microphone? Yes, okay.
Yeah, I feel that while you're talking about global health challenges, that some mention should be made of the famine in Somalia. And I was wondering if anyone wanted to comment on the political challenges of an international response to a situation like that.
I think that's a Neil's question.
I'm really not sure where to begin. I was just in East Africa with Secretary Sebelius last month, and we couldn't even go to the refugee camp because of security concerns. Al-Shabaab had been established there, and there were concerns about terrorism. It's a perfect storm in many ways between social breakdown, environmental collapse, overpopulation and population growth, unlimited resources. I don't think anyone has come up with a good answer for how to deal with it. It's certainly not for lack of attention, and there's certainly resources being pushed at that constellation of problems, but I don't think we've got a good approach to it, and I'm not sure anybody does at this point, to be honest.
I mean, the issue of conflict. This question rolls up lots of different issues. You know, the issue about religious beliefs and how they affect, you know, how you view people and populations. But the issue of conflict is, I mean, it makes it difficult to do anything, right? And you know, the most controversial research that's come out of the school since I've been dean it's not controversial in terms of the methodology, but the impact of the findings was, you know, the Iraqi mortality study that Gilbert Burnham did, and people just didn't want and still don't want to accept that many people are killed, you know, as a byproduct of conflict. And so it is difficult as an American to watch the news and see those videos, and it's not the first time it's happened to us, but to feel for the death of the women, children, and others there, and not be able to do something. I mean, but then I think that we don't have the political will to solve problems in our own country. I mean, it's this division and partisanship it makes life very difficult. And I wonder whether the gerrymandering of you know, Senate and House districts has contributed to that, because now we have Republican districts and Democratic districts that don't allow an elected official to be a moderate, right? Because they won't be.
In primaries.
Yeah. So Jim, let's wait for the mic. Could we get Dr.
Can I
Kobe
just
the mic?
make
Yeah,
one note
sure.
while we're waiting for that? I'm deeply concerned that we're one hurricane or other issue away from having Haiti in the same condition that Somalia is in.
Yeah.
I think it's a heavily armed place with all of the breakdowns that we've seen in the Horn of Africa, and it's going to be a lot more impactful in terms of the U.S. body politic.
But in terms of Somalia, can't the ICRC get in when no one else can?
In some instances, but they can. I think in Somalia right now, everybody's having a very hard time getting in, at least beyond the camps, and even the camps are enormously challenging.
Okay. Any other final comments before we start? No? If not, I want to thank you all.
Can I make one closing comment?
Yeah.
I realized on walking into this lovely room that I came into this room 34 years ago this week, and that I met the new dean of the Johns Hopkins School of Public Health, Dean Henderson at that point, now my friend D.A. But I also just wanted to note that in this room 34 years ago next week, I met my wife.
More important than the dean, right?
That's a good way to close. Okay. So thanks very much. Maybe I'll ask you to take a seat, and I'm going to introduce, well, first, you know, these awards that we're going to present are given by the Johns Hopkins University Alumni Association. And this is an organization that, you know, represents all the alumni of all parts of the university. And the awards are given by consensus of that group. So it's not just our school that votes on this. In fact, our school is a very small minority of alumni. But we have several members of our alumni council here in the audience who represent us there, and we're thankful for their hard work on our behalf and for their advocacy. And I want to introduce Nicholas Mathis, who is a graduate of the school. He has an MPH in International Health from the school in 1988. He has been a devoted member of our Alumni Association and now our Dean's Alumni Council. He's an assistant professor in the health in the school in the Department of Health Policy and Management, but he lives in Philadelphia and works there, and he makes this trek down to the university for the meetings to make sure that public health is represented at the Alumni Council. So, Nicholas, please come up. We thank you for all your work.
Well, thank you very much. Before getting started, just some logistics. What I'll do is I'll read the bios of the people who are receiving the award, and if you would just wait until we finished reading the bio and then come up and receive the award from Dean Klag. So I'll get started with Nicholas Büscher. I'm German, you've probably heard it, so I'll pronounce it the German way. After his graduation from JHSPH in 2005, Nicholas Büscher returned to Fairview Southdale Hospital in Minneapolis, where he completed his Master of Health Sciences field placement as Director of Oncology. In addition to increasing the oncology service line outpatient revenue from $6 million to $44 million, under his leadership, the program grew from 9th to 4th largest in the Twin Cities. Within 18 months, he led an unaccredited program with multiple deficiency to accreditation with commendation status. In 2006, Fairview Southdale received the Surgeon's Outstanding Achievement Award and ranked in the top 6% of cancer programs. In 2008, Nicholas became VP of Oncology for Mountain States Health Alliance in Johnson City, Tennessee. At MSHA, he is responsible for oncology service lines at an integrated delivery system comprised of 15 hospitals in Tennessee and Virginia. Nicholas is also the president of the American Cancer Society Tri-Cities Leadership Council and was recognized by the Business Journal as a member of the 2010 class of 40 under 40. Nils Dollaire. Dr. Nils Dollaire joined the Department of Health and Human Services as Director of the Office of Global Affairs in March 2010. Prior to his appointment, he served for over a decade as President and CEO of the Global Health Council, where he coordinated extensively with international leaders, governments, and United Nations organizations to improve public health in the world's poorest communities. From 1993 to 1998, he served as Deputy Assistant Administrator for Policy and a Senior International Health Advisor for the U.S. Agency for International Development, where he oversaw an integrated global strategy encompassing health, population, hunger, girls' education, and other social sector programs totaling over $1 billion annually. He was the lead U.S. negotiator on health at the Cairo International Conference on Population and Development in 1994, the Beijing World Conference on Women in 1995, and the Rome World Food Summit in 1996. He has represented the U.S. at 5 World Health Organization annual assemblies. Prior to his government service, he spent 15 years in the field in low-income countries, managing maternal and child health delivery programs in countries as diverse as Nepal, Haiti, Mali, and Bangladesh. Susan R. Guarnieri. Dr. Guarnieri is well known for her public health work in Baltimore and the state, especially her work to support mental health facilities and AIDS clinics in Maryland. She has received numerous awards from the legislature and governors for her work as Baltimore City Health Commissioner, President of the Baltimore City Medical Society, Delegate to the Maryland State MedChi Society, Chair of the Governor's Commission on Women's Health, Vice Chair of the state's Health Services Cost Review Commission, Board of Visitors, University of Maryland School of Medicine, and work with the Association of the Maryland Hospitals and Health Systems. In 1984, she became the first woman to head the Baltimore City Health Department, and in 1987, Dr. Guarnieri became the medical director of the Baltimore Gas and Electric Company and Constellation Energy. In 2006, she became the acting commissioner of a health department in Phoenix, Arizona. Within a year, she developed the policies and procedures that Phoenix needed to bring on a permanent commissioner. Currently, she serves on several local hospital boards, including Maryland General and GBMC. Joanne Katz. Joanne Katz's impressive career has been marked by key findings in ophthalmology, nutrition, and reproductive, maternal, and child health. She has spent decades working diligently on collaborative research projects that aim to reduce mortality and morbidity in underserved populations, both in the US and overseas. A professor in the Department of International Health and director of the Global Disease Epidemiology and Control Division, her specific areas of focus include macro and micronutrient deficiency, neonatal and maternal health, the interaction between nutrition and infection, and ophthalmic epidemiology and blindness prevention. Some of her key research projects have focused on iron and zinc supplementation for preschoolers and antenatally, maternal influenza immunization, and newborn vitamin A supplementation. She has also been involved in the very successful Jivita project in Bangladesh, one of the largest nutrition trials of its kind, which has recruited 100,000 pregnant women and their babies. Virginia Ladd, friend of Johns Hopkins University. Virginia Ladd is the founder and chair of the American Autoimmune-Related Disease Association. Since 1991, Mrs. Ladd has led AARDA, and it has organized cutting-edge scientific meetings and established the National Coalition of Autoimmune Patient Groups, an expansive group of 31 national autoimmune disease-specific groups who use their collective influence to advance autoimmune disease patient advocacy and awareness. Additionally, Mrs. Ladd fought and won to have autoimmune disease recognized as a category of disease. This new category includes more than 100 diseases which share a common cause, autoimmunity. Today, under Mrs. Ladd's leadership, AARDA is an internationally recognized authority on autoimmune disease-related issues. Patricia Mechel. Patricia Mechel works in the field of mobile health, or mHealth, initiatives, the practice of medicine and public health supported by mobile devices. She is the mHealth and telemedicine advisor to the Millennium Villages project at the Earth Institute at Columbia University, working on the strategic integration of mobile phone-based applications for the achievement of the Millennium Development Goals in collaboration with Ericsson and mobile phone operators in 10 countries in Africa. In addition, she has been engaged in mHealth research and strategic planning with the Global Observatory for eHealth at the World Health Organization and the Inter-American Development Bank, and serves on the steering committee of the newly launched mHealth Alliance, a collaboration between government, international organizations, non-government organizations, and private corporations to improve health outcomes in underserved communities. She provides guidance on the strategic application of information and communication technologies to CARE USA, Catholic Relief Services, the Inter-American Development Bank, the Johns Hopkins Center for Communication Programs, Abt and Associates, the UK Partnership for Global Health, and the World Health Organization Global Observatory for eHealth. Donna Peterson. Donna Peterson is Dean of the College of Public Health at the University of South Florida, the Director of the Patel Center for Global Solutions and the Interim Executive Director of USF World, an umbrella initiative that captures USF Strategic's effort to provide opportunities for USF students to study abroad. Prior to joining USF, she was professor in the departments of maternal and child health and healthcare organization and policy at the University of Alabama at Birmingham School of Public Health. Previously, she served as the Senior Associate Dean for Academic Affairs at the UAB School of Public Health and the Director of the Division of Family Health at the Minnesota Department of Health. She has been honored for her work by the American Public Health Association, the Association of Teachers of Maternal and Child Health, the National Healthy Mothers, Healthy Babies Coalition, and the Delta Omega National Public Health Honor Society. Caitlin Reed. After graduation, Caitlin went on to form a partnership between the Bloomberg and Mighty Nepal, a non-profit organization based in Nepal that takes in hundreds of girls and women who have been cast away by their families and communities because of their involvement in sex work. This year, Caitlin received the good news that Mighty Nepal had been awarded a $500,000 grant by the US State Department Office to monitor and combat trafficking in persons. Along with 4 other alumni, Caitlin traveled to Nepal, where they performed a stakeholder assessment of the organization, provided grant-writing training to Mighty Nepal staff involved in HIV treatment review, and performed clinical work. In Baltimore, the team organized a fundraiser, hosted speakers, and screened a documentary at the undergraduate campus. With colleagues, she drafted Mighty Nepal's first strategic plan, mentored the staff, developed a funding proposal, and investigated and reported on cases of organ and sex trafficking. Mighty Nepal can now offer improved HIV treatment regimens, cervical cancer screening, and rehabilitation programs for the girls who have been abused, some since the age of 9. Diane Rowland. Diane Rowland is Executive Vice President of the Henry J. Kaiser Family Foundation and has been Executive Director of the Kaiser Commission on Medicaid and the Uninsured since 1991. In 2009, she was appointed the chair of the Medicaid and CHIP Payment and Access Commission. MACPAC is a nonpartisan congressional advisory body charged with providing health policy advice and technical assistance to Congress. Dr. Rowland's federal health policy experience includes service as a senior staff associate on the Subcommittee on Health and the Environment of the Committee on Energy and Commerce in the House of Representatives, as well as senior health policy positions in the Department of Health and Human Services. She is a member of the Institute of Medicine, a founding member of the National Academy for Social Insurance, past president and fellow of the Association for Health Services Research, now Academy Health, the Secretary's Task Force on Infant Mortality, and the Commonwealth Fund Task Force on Health Insurance for Working Americans. Dr. Rowland is also on the board, a board member for the National Campaign to Prevent Teen and Unplanned Pregnancy, and has served on the Commonwealth Fund Commission on the Future of Health Insurance. Gregory Tignor. Gregory Tignor is an arbovirus researcher who has worked on over 300 arboviruses throughout his career, first becoming interested in the study of arboviruses during his work on his doctoral dissertation with Dr. Winston H. Price at the Johns Hopkins School of Public Health in the late 1960s, devising a system for rapid diagnosis of selected arbovirus infections. Dr. Tigno later left the school for the Yale Arbovirus Research Unit, where he was to work with Dr. Jordi Casals, a giant in the arbovirus field. Here he worked on Lassa fever, hemorrhagic disease in Africa, and the Onong Nong virus in Uganda. In his later collaborations with Dr. Casals, Dr. Tigno was instrumental in adopting more stringent rules for biological safety, such as anti-smoking regulations in laboratories, the wearing of special suits with respirators, the introduction of various devices using to avoid mouth pipetting, the purchase of one of the first biological safety hoods ever made, and ensuring that laboratories operate under negative pressure. Due in part to the success of some of these measures, Dr. Tigno was elected as a counselor of the American Society of Tropical Medicine and Hygiene. David Vlahoff. David Vlahoff is Dean and Professor at the University of California, San Francisco School of Nursing. He was formerly the Director of the Center for Urban Epidemiologic Studies at the New York Academy of Medicine and a Professor of Clinical Epidemiology at the Mailman School of Public Health at Columbia University. Dr. Vlahoff has conducted studies of urban populations in Baltimore for over 20 years, including several longitudinal cohort studies for which he received the NIH Merit Award. In the mid-1980s, he launched the ALIVE study in Baltimore, which has provided seminal insights about the epidemiology of HIV/AIDS, as well as the effectiveness of antiretroviral treatment and HIV prevention. More recently, Dr. Vlahoff has led epidemiologic studies in Harlem and the Bronx, which have served as a platform for subsequent individual and community-level intervention studies and community-based participatory research to address the social determinants of health. This work has contributed information on racial and ethnic disparities in health and approaches to address such disparities. He founded the International Society for Urban Health, serving as its first and current president. The Society brings together an interdisciplinary and international group of scientists to examine the health effects of urbanicity.
So, thank you, Nicholas. Thanks for that and for all that you do. I just want to tell those of you who received awards made of glass, we do have the cases up here, so if you want to come up afterwards and get the case, and then if you'd like, we can ship them to you. But I want to thank everybody for coming. We have great alumni. This is a small sample, but a sample of the best. And so thanks for making so much time available from your busy schedules to come here and be with us. We're having a reception outside, so please join us for some beverages and wine and cheese. Well, probably not fruit and cheese, maybe. No, fruit and carrot. No. So for some healthy food out in the by the Wall of Wonder. So thank you all.